Okay, some disclosures you see up there. The most important ones are all the way on the right. I like to do mountain biking and photography and some, product innovation. So the CurvaFix implant is FDA approved. It's been on the market and being used. More than 100 cases have been done, so it's really a startup, but doing cases. The question is, why actually have a new pelvis implant? I mean, what's the big deal? So the reality is that the pelvis has intraosseous corridors that are curved, and most studies that are done out there looking at corridors really think about a straight screw going through a curved path. And I'll show you what I mean by that in a second. Remember that larger implant diameters also increase the stability of any intraosseous fixation. So if you think about a nail in the tibia or in the femur, you increase the diameter by 1 millimeter, and then you increase the stiffness by a third order magnitude at least, depending on the diameter. This implant, at least, has been shown to decrease pain immediately and allows patients to mobilize pretty quickly. Over 50% of these patients are elderly, older than 65. And there is a study that has already been done called the RESTORE study, which I'll talk about in a minute. And then there's a new study, RESTORE PME, if anybody's interested, but it's basically a study looking at consecutive cases that is currently underway. So this is kind of the patient experience. It's more than 115 patients now. I think it's probably more like 130 something. 71 of them, or 62%, are high velocity trauma, fragility fractures, and 32%. Revision of those 115 only occurred in 3, meaning that these were revision surgeries for other implants that were performed. Oncology patient 2 and implants about 150 in those 115 patients. More than 65-year-old patients, we're looking at 58%. And then they're used all over the pelvis, posterior pelvis, anterior pelvis, acetabular column implants, so anterior, posterior column, et cetera. And then iliac wing, like LC2 type implants. So why is this compelling? In my mind, it's compelling because, as I said, the pelvis has corridors that are curved. You have the anterior column, posterior column, LC2 or iliac wing, and sacral corridors. Screws are straight. Screws are generally used like intramedullary nails. They can compress fractures, which a curved implant really can't. And they cannot fill the inner walls when used in a curved corridor. I'll show you what I mean by that in a second. So they can't be as large as a curved implant, especially if it's flexible and then gets locked. So you have something that looks like that. That's like an anterior column screw. And you can see that that's the size of that implant, and a much bigger implant, if it's curved, is able to fit in that corridor. And that's been borne out by at least clinical experience. This is a classic view of the cross-sectional anatomy and corridors into the S1 body. What you see here is essentially, this is the L5 nerve root. Really, it's L5, L4, and obturator nerves are sitting there. And then you don't want to be in front of this red line or behind this red line. That's your corridor. And traditionally, you're going to put a screw in that looks like that, or a transsacral screw that looks like that. Really, we all wish, though, that we had a screw that looked like that, which is much bigger, much more stable, and is able to get around the corner. And this is an example down, I'll show you this case in a minute. It's a dysmorphic patient with a dysmorphic upper sacral segment where you have to have a curved implant if you're going to S1. Usually S2 is a big corridor. You can put something straight in there. But S1, if you want to capture that, you have to have a curved implant. So the reason why I'm excited about, one of the reasons why I'm excited about this is because we did a study looking at dysmorphic pelvis patients with dysmorphic pelvis fractures, SI screw placement. This is a multi-center study. It was a randomized study looking at fluoroscopy navigation, and then 3D navigation. And the main outcomes were looked at with post-op CT measurements of sacral wall penetration, meaning you put a screw in, and then if it hits the wall, it goes through the wall. That means that that's not where you want it to be, right? You want it to be inside the corridor. And the percent of agreement between 6 observer looking at all the CTs was 69%, which is really good. Kappa 30.38, P less than 0.05. So with fluoroscopy, missed screws, 11.9% non-dysmorphic group, and then 28% in dysmorphic group. So much higher rate of missed screws in patients that have an unusual anatomy of the upper sacral segment, which is what's expected. So, the bony anatomy, this is just a sawbones, but bony anatomy, as you can see, these curved corridors exist in the pelvis. And if you look at how this implant actually works, you basically put a guide wire in, followed by a reamer, and then there's a steerable ball tip guide wire that you can move along. It's hard to see, but I'll show you guys cases that you can move along within the corridors and actually bounces off the inner part of the corridors under fluoroscopy. And then you can curve it so it stays within the correct trajectory within that corridor. And you put it in, you twist it, you tap it in a little bit, twist it, tap it in a little bit. And then after that, you basically ream with a reamer. And then you put an exchange, it's a ball tip, so you can ream over it, and if there's a problem, you can pull it out. And then you exchange it for a exchange tube for a smooth guide wire, which is what you see there, and then you put the implant in. Pretty straightforward. And then after you put this implant in, you can actually lock it. So there's a little screwdriver you put in the back, and you just twist it, lock it, and then you unfasten it, and that's the end of it. So pretty straightforward. It's a few more steps than putting a screw in, but it's pretty easy to use, actually. So Restore, we did a clinical study looking at this. These were just the first 25 patients, essentially, looking at the safety and technical feasibility. The idea was basically just to fix the pelvis and acetabulum. It was a prospective multi-center single-arm non-randomized study. And the primary objective was were basically to evaluate the safety and technical feasibility of the CurvaFix implant. Inclusion criteria was almost everybody over the age of 18 and less than 70 years old. These are all the sites. So in San Jose, California, UT Houston, et cetera, as you see up there. They had 25 patients with 27 implants placed. Again, this is just an initial clinical trial, right? So this is just to make sure this thing actually works and the instruments work, et cetera. And 81% of the patient ambulated at discharge. So how many of your pelvis, fracture patient actually ambulated at discharge? It's pretty good. 100% were ambulated 3 months. 96% maintained implant stability, which means that nothing moved. And the complications, there was one implant that backed out of the posterior wall column screw, which was actually double reamed. So there was like an error in the procedure, one of the first implants. And two, the instruments had to be changed. And so there was a problem with the instruments, but it didn't affect fixation. And all that stuff has been fixed since that time. So here's a couple example of cases, and then I'll give it to our other speakers. Mildly displaced anterior column with posterior hemitransverse acetabular fracture. It's hard to see it, but on the CT you can see it, like right here, right there. So you could decide to leave it alone or to do something with it. If you let them walk on it right away, you can give them that option. That's what we did. So here's how it looks. Anterior column screw, essentially initial reaming, which you can see here. So that's initial reaming after putting guide wire in. The steerable ball tip guide wire is then tapped in into the corridor, and you can see how it's nice and curved. You can curve it in there, and then reamer, followed by exchange, and then putting the screw over it. And you can see how the screw just follows the corridor. So it kind of bounces off the inner walls and follows the corridor, and always have a posterior column screw there. Another one, this is a 70-year-old male with jujitsu master who was moving a deer from the road and was hit by a car, right? So a good Samaritan gets hit by a car. He's got this pelvis fracture, and I'll show you what that means in a second, and he's a polytrauma type patient. He's got a sacral fracture, essentially. You see that's kind of through and through over here, as well as the anterior part of his pelvis is also broken. Same idea here. His S1 was very dysmorphic, so we went actually into S2, and you can see the screw going in the same way as we talked about before, just following the trajectory. And you can see the same thing here and there. He's 1 year post-op now, really just complaining of pain in this plate. That's all he's complaining of, no back pain, no problem with his posterior fixation. And then the last one, this is a 24-year-old male who has an APC type 3 pubis symphysis dislocation, and the posterior part of his pelvis is actually fractured, not open. So it's kind of an unusual pattern where the posterior ring is not open through the SI joint, but really there's a fracture in posterior and proximal displacement of this left hemipelvis, as well as distal radius fracture, which we're not going to talk about. And he's got a sacral upper segment, which is a little bit dysmorphic. And the whole idea here is, if you can imagine what the screw actually sees, so you're inside the tunnel trying to get to where you're supposed to be getting to, and it looks like something like this. It's basically like being on a train track and trying to get around a corner. That's kind of what it looks like. And if you're the screw actually looking at your trajectory through the corridor, it actually looks like this, right? That's what it actually looks like, because these things aren't really straight. So if you want to fill that whole curved channel or the whole curved corridor, the way you'd have to do it is with something that's curved, not straight. So in this particular patient, you saw, I'll go back here just for a second so you can see. So he had, open pubis here, and as we said, he's got this fractured sacrum in the back here. And you can tell, from the pre-op CT that he's got dysmorphism in the upper segment, because the trajectory to place a screw would be basically, from posterior to anterior, pretty steep trajectory here. And then you can also see on the coronals that basically you have these, you can't find a corridor where you actually have a straight shot. This is S2 down here. So the idea is, as I said, filling something that's curved. And we know that the bone is much better up at S1 than S2, right? Anybody who's done pelvis fracture, try to compress through S2, you'll see that the bone there is not very good. So here the idea was we fix the front and then screw the back. So compress the front with a couple of clamps. I like to put sometimes 2 of these in order to really get compression. Fix the superior ramus here, and then I double plated them because I was scared that it would not work with one plate because of all that force. And then and I'll show you the intraop CT, but the next thing we did is actually put a straight screw in S2 that was a compression screw, because, as I said, you cannot compress through using a curved implant. You have to do something else to get compression. And then we essentially, the entry point over a guide wire. And the idea here is that this entry point doesn't have to be perfect. It has to be close to perfect, but it doesn't have to be perfect. It takes a little bit less time to find it. And the reason why that is because you have a curved implant that's going to go into the corridor where it needs to go. So it's not like a straight shot. It's easier to get it in there. So this is the steerable ball tip guide wire that's tapped in. That's the outlet view and the inlet view, and then the reamer goes over it, followed by an exchange tube, which you can hardly see because but there's an exchange tube here. And then we put the implant in, essentially over the guide wire, lock it, and then just disengage the inserter, and then you have a locked implant that's sitting there. It's pretty straightforward. That's what it looks like with intraop verification. This is our S2 screw that's going through the S2 corridor. Here's the CurvaFix implant that's going through S1. And again, you can see that because there's dysmorphism, you can't see this whole corridor on this view. You can see it on this view, but you can't really see it on this view. And the fracture is, I think, pretty close to being reduced. So that's what it looks like post-op. There's 3 months. Our X-ray tech was very excited about doing outlet view. And then last one, 24-year-old female right sacral fracture, another dysmorphic patient. I'll show you the CT. So she's got this very small corridor. If we want to put a screw in there, we can go to S2, but our S2 is also pretty small. This is how we want to put that screw in. And again, the same idea, cove over the top. The interesting thing is, and I've learned a lot actually from this implant, is that the corridor sometimes isn't what you think on the inlet view, because as you see here, essentially the screw goes in and then it goes a little bit posterior. See that? So her corridor actually isn't on the inlet view, isn't straight or from back to front here. It's basically coming in, it could have been back here to back there. So back, front, back. And you'll see that on this is the real outlet view here. You can see how it comes in and then it goes posterior. And I was kind of worried because I didn't know, I was worried where this was. So I just stopped it short of the SI joint because I was kind of worried about it. But here's how it looks holding that fracture 6 months post-op.
Objectives, I'm just going to go through 2 case examples of CurvaFix. One's going to be a pelvic fragility fracture. I think that's going to be the kind of the workhorse of what this implant can do. I think we see a lot of pelvic fragility fractures, at least in my practice, that I really wasn't treating with surgery, and this has kind of changed the way I approach those patients. And one traumatic injury in an active patient. What I want to show is kind of the ease and safety of the CurvaFix nail. What I found is that putting this in turns out it's a little bit easier because the wire is going to kind of bounce around and go where you want it to go. And that kind of makes it a little bit easier, especially in these tough cases like the dysmorphs. And then the clinical benefits, hopefully we'll show through in this. So why CurvaFix? And Amir kind of already talked about this with a device that fits the anatomy of the pelvis. You've got curved corridors, and we're trying to put straight screws in those. Using a curved implant will fit those corridors, but the other thing that a curved implant does is when you lock it, it's nearly impossible to pull that out. I like to tell the story when I was 17. I used to think I was going to be a race car driver, and I used to practice in my neighborhood. And I was turning a corner when it was wet, and my car hit the curb, and I bent the axle, and it didn't really turn after that. It didn't move the wheels. So having that curved implant locked isn't going to back out. Like normally with straight implants, when you walk, you get that motion, and the screws start to unwind and back out. This doesn't do that. At least I haven't seen it yet. It's safe, and one of the things that I talk about is the feel you get from the guide wire when you're putting it in. I would never try this, but I like to think that you can almost put this in without x-ray because you can feel the difference between cancellous bone, cortical bone, and when you're not in bone. And it's kind of like a straw in a cup, like you can feel that sliding. When you hit the ice here in the cancellous bone, it gives a little bit of crunch and resistance. When you hit the bottom of the cup, it stops. You know you're on cortex. When you hit that, you can get an x-ray. You can say, all right, I'm on a neuroforamen, or I'm trying to come out the front of the sacrum, so you can stop. And then the biomechanics, again, being curved. I also feel like, a straight solid piece of metal, if you give that a little bit of bend, it's going to find that weak spot and break. This has a little bit of give into it, so it's not really going to break. It's going to kind of hold with the normal motion of fractures and hopefully be within that range that allows us to heal. So I'll start with patient 1. This is my 62-year-old active water skier. He was at Lake Shelbyville, which is right near Springfield, home of the Simpsons, and fell off the top of his camper and came in with this. So he's got bilateral rami fractures and a sacral fracture in the back. So I have a couple of CT cuts showing this. And I classified this as an LC2. So I always try weight bearing on these patients, especially with the fragility fractures. If they can weight bear with their fractures, I don't do surgery. If they can't, then I like to do something about it. So he failed weight bearing with therapy, and I then discussed surgical options using CurvaFix, talking to him about, hey, this is a fairly new implant. I've used it quite a bit. It's worked very well. I also talk about the postoperative course. So these patients, I like to get them up and start them walking right away. And he was very excited about that, wanting to get back to water skiing as soon as possible. So we took him to the operating room on post-injury day 3. And I think the booth is going to have some videos of I like to save every x-ray sometime on these, and so it's like a cartoon of the process of putting this in. And I gave this guy what I like to call the full Monty. So he has the posterior screw and then right and left column screws. I made him weight bearing as tolerated immediately after the surgery. At week 2, he came in with a cane and said things were going well. I think if you compare the column screw on the right, it did move a little bit, but it's still holding. And then at week 6, he came in with a cane, wasn't complaining of any pain, and was ready to get back to work. He had a job where he's on his feet at the Caterpillar plant all day long. So within 6 weeks, this patient was back to walking and ready to go back to work. When before, I don't think I would have gotten this patient better that quickly. So at 10 weeks, he's got no cane and no pain. And you can see, I think you can see he's got a lot of good callus in the front, showing that this is stable. Patient 2, this is a 72-year-old female with a ground level fall. This patient came into the emergency room with this x-ray, was told everything was fine, and sent home. This patient lives alone, is very active. She was unable to walk for 5 days, came back into the emergency room where we got a CT scan showing really non-displaced on the left sacrum, but bilateral sacral fractures, and then a small fracture in the front. So I classified this as an FFP4C for Dr. Rommens, bilateral sacral fractures, right symphysis. On post-injury day 6, so this is a day after she came in to our hospital, so I had at that point considered her to have failed weight-bearing therapy, being home for 5 days and not being able to walk. So we took her to the operating room the next day, placed this implant. Here's a CT cut showing its placement. You can see the large curve in this, which I like to put large curves in. I've noticed in some labs that if you put this in with your hand and just kind of shake your hand, it goes in straight. I think that defeats the purpose of putting this device in. You want to get a curve in there. And actually, when I start these cases, I always start sacral screws with my lateral imaging, mark where I want my start point. But on this, I mark where I want my start point, and then I move it one way or the other. If they're dysmorph, I move it posterior. If it's a normal sacrum, I like to move it inferior to get a curve moving towards the spine. So post-op CT looked great. The patient came in 2 weeks carrying her walker, and she said, "I'm not sure why I'm carrying this around." And I think it was one of those things where the patient came in because she thought I wanted to see her using her walker, but actually she didn't need it. But she actually went to a rehab facility. I think she spent 5 days there and then was back home living alone shortly after that. And 4 months post-op, the patient has no issues. And so here's my x-rays of her. So to recap this, one, I think CurvaFix is safe. I believe it's easier to put in, and that's the nature of the curve. You can bend and bounce around the structures that you don't want to hit. It fits very well, and I think it's going to allow us to kind of rethink pelvic fixation strategies. We have all these defined corridors, and I think what this gives us the ability to do is potentially connect some of those corridors with large curved implants. So, thank you.
Good morning, ladies and gentlemen. I'm happy to be here, to be invited for this early morning session. And my talk is about fragility fractures of the pelvis, and the subtitle, "It's an underappreciated and growing problem." I will try to show you that. First of all, the definition. What is a fragility fracture? This is the definition of the World Health organization. It's a fracture that is caused by an injury that would be insufficient to fracture normal bone, the result of reduced compressive and or torsional strength of bone. That includes the osteoporotic fractures, the insufficiency fractures, and the geriatric fractures. So here we are looking at a growing elderly population in most of our industrialized countries. You see I was working in Germany. Japan has the oldest population in the world with a median age of 46, and immediately thereafter, Germany with a median age of 45. That means that 50 million people in Germany have the age of 45 or above, and the same is true for Japan. And you see the median age of populations in different large countries over the world in this slide. Here is the publication of 2015 that was looking at the discharge diagnosis of Medicare patients in the USA between 1993 and 2010. So it's an 18-year period. And you see the total amount of discharges is about 250 million. Traditional hip fractures count for discharge diagnosis in 3.5 million patients in this time period. Pelvic fractures only 500,000, acetabular fractures less than 100,000. But if you look at the incidence over time, then you see that there is a peak incidence in the, I would say, classical geriatric hip fracture in 1996, and it's going down by 25% until 2010. And the opposite is true for the pelvic fractures. So you see here a low incidence in 1993, and it's steadily increasing, again, an increase of about 25% over this 18-year period. Certainly, the absolute numbers are different. We talk about 100,000 and 500,000, but still it's a very important trend that you see in increasing incidence of pelvic fractures and decreasing incidence of traditional geriatric fractures. And I show you now some publications from Europe that are showing you that this is not a trend, this is really reality. So here a publication about the low trauma pelvic fractures in elderly Finns between 1970 and 2013 with a projection 2030. And you see there is an increasing incidence, age dependent, in females and in males over this time period. And there is a projection that this will go on with a steep increase until 2030. Also, another publication from Germany, from data of the insurance companies, where you see a sharply increasing incidence beginning at the age of 80 in male and in female patients. These are data from the pelvic trauma registry in Germany. You see 3 different time periods, 91 to 93, 98 to 2002, and 2004 to 2010. And you see a shift in the incidence of these pelvic fractures that is very clear. In 91 to 93, we had a majority of persons that suffered pelvic fractures being young and male. And here you see a shift towards older female in the period that is only 10 years later or 15 years later between 2004 and 2010. In Austria, the same problem, a very recent publication, data from 2010 to 2018, conclusion, there's a clear increase in the incidence of pelvic fractures in elderly population. The same is true for Switzerland. Here you see demographic changes in pelvic fractures at the Swiss hospital. The demographic shift especially includes the older female population. As a USA publication here, nationwide analysis of pelvic ring fractures, incidence and trends in treatment, length of stay and mortality. And you see an increase of the incidence, a decrease in hospital stay when patients are operated, and also a decrease in mortality when patients are operated. And because I'm from Belgium and I have the Belgian nationality, I had to add this publication, recent publication as well. It's a very small country, but nevertheless, also there is an increasing incidence of pelvic and acetabular fractures, with the majority of these fractures being in the older population. So we see all over Europe and also in the United States the same trends, that I would say reality of an increasing incidence of fragility fractures of the pelvis. Now, what are the differences between pelvic lesions in adults and in the elderly? There are a number of differences, but the most important ones are the quality of the bone and the different morphology, and also an increasing instability over time that may happen in patients that are treated conservatively. I show you here a publication here in collaboration with the AO Research Institute in Davos. One of my staff members, Daniel Wagner, he performed 3D statistical modeling of the sacrum to investigate the anatomy, the bone mass distribution, and the transsacral corridors. And you see here two different groups within these 92 Europeans. This is a group with a higher bone mineral density measured in L5, more than 100 Hounfels units. And this is a group with a lower bone mineral density, lower than 100 Hounsfeld units in L5. And here you see these yellow islands. These are so-called alar voids. That mean there is no bone structure anymore. The density is equal to water. And these patients with low bone mineral density, you see that these alar voids are very large, and they are always situated lateral to the neuroforamina, so in the sacral ala, that's called alar voids, and some small islands here in the middle of the sacrum, not in S1, but in S2, 3, and 4. And that explains the specific morphology of these sacral insufficiency fractures that we see in these FFPs. They are always situated, or nearly always situated, in the lateral ala, in the lateral part of the sacrum, near to the sacroiliac joint. They can be unilateral, they can be bilateral, and there can be an incomplete or a complete transition between these two vertical fractures. And here we are talking about an H-type injury. In adults, this is a spinopelvic dissociation, but in the clinical condition of the patients with this H-type injuries in the elderly is totally different. So it's not a suicide jumper fracture. And here you see one of these patients. It's an 83-year-old female, 3 months after the onset of complaint. So she did not remember any fall, she did not remember any trauma. And you see here, it's like an implosion of the whole pelvic ring between intact ligaments. You see on the left side, on the right side, and in the anterior part of the pelvis, fractures with huge dislocations. Patient is nearly not able to walk anymore. Another patient is an 81-year-old female, recurrent falls, pain since months, conservative therapy, and you see here this very impressive implosion. You see the left and the right sacral fracture. You see an anterior dislocation, but you see especially in this sagittal CT reconstruction a horizontal fracture with a flexion displacement between S2 and S3. And that was the reason for us to look back at our patients. We looked back at 245 patients and found different morphologies and different characteristics that were not the same as in high energy adult fractures. And that was the reason for the development of this new classification with 2 criteria. The first criterion is the degree of instability. And the second criterion is the localization of the fracture in the posterior pelvic ring, because this has an importance for the type of treatment if you want to operate. So you see here the FFP1 is an isolated anterior lesion. The FFP2, the largest group, are undisplaced or nearly undisplaced posterior lesions. Then you have 3 and 4, which are the displaced unilateral and displaced bilateral posterior lesions. So now the question comes up, what should we do with these patients? And in our original publication of 2013, we connected this classification with recommendations for surgical treatment, especially in the unstable fracture types. And this was the treatment algorithm or therapeutic algorithm that we recommended. The blue zone is the conservative one, the red zone is the operative one, and depending on the type of fracture or the localization of the fracture, we had different types of treatment that we recommended. And show you now some of the results that we had in Mainz University, and indeed we looked back for 10 years and found 519 patients with fragility fractures of the pelvis over a 10-year period. And our study nurse called all of these patients at home, or if they were not at home, they called the families and asked how they were doing. And you see here the FFP2 types, so were 238 patients. It's about 46% of the whole group. And in 3 quarters, we treated them conservatively. In 1 quarter, we treated them operatively. The median length of hospital stay in this group of 238 patients was 10 days, and 1-year mortality of 14%. And you see here 2 parameters, a reduced mobility and a reduced quality of life in the whole group. But if you now subdivide and you compare the operative with the non-operative group, you see that there is a significant difference what concerns mortality. So here you see the Kaplan-Meier curve, and the patients that were operated have a lower mortality than at 1 year, at 2 years, and at 5 years than the group that was treated operatively, conservatively. And the same is true for the 3 and 4 types. So these are the more unstable fracture types. You see it's about 1/4 of the whole group. And here we treated only 30% conservatively and 70% operatively. 15 days hospital stay, 1-year mortality about the same as in the FFP2 group. But again, we have a lower quality of life and a lower mobility and independency in this group. But again, if you compare the non-operative with the operative group, you find statistical significant difference in the mortality rate between the operative and the conservative group at 1, 2, and 5 years. So this was very important to us. In Mainz, we tended to use this transsacral implant. It's a straight implant of 6 millimeter. It's a bar that is connected on the left and the right side with nuts and a washer. You see the washer is pushing against the lateral cortex of the posterior ilium on both sides. So you develop some interfragmentary compression, and that avoids the loosening of this implant. But it's a straight implant. And here is one of the examples. It's a FFP2C lesion, failed conservative treatment, and here you see a transsacral implant with an additional iliosacral screw and a retrograde transpubic screw for the front. And you see these, I would say, ideal position of the transsacral implant in this patient. Another patient with an FFP3C lesion, you see a huge instability in the front as well, not at the pubic rami, but here situated at the symphysis pubis itself. And then let's say, it's like a pseudarthrosis. It's a non-healed lateral sacral fracture in the back. 2 months conservative treatment. And here you see the transsacral implant, additional iliosacral screw, double plate osteosynthesis because of this chronic instability in the front. And this is also the transsacral implant. We looked back at our patient population that had this implant. These were 85 patients. We needed an operative revision in 15%, which is quite high. 1 year mortality was below 10%, a follow-up of on average of 3.2 years, and we could find 85% of them living at home and 82% walking with or without a walking aid at 3 years. That's for us a very good result. So only here 15% of revision is, I think, too high for this time. So then we looked at the space available for the transsacral implants to treat these fractures with this straight implant, the same outers. And here you see we looked at the CT scans of 156 individuals, and in only 51% of these pelvises, there was a, let's say, a corridor available with a safe zone for an implant of 6 millimeter diameter in S1. 22% did not offer enough space in S1 for an implant, even when ignoring the safe corridor. And in S2, this is better, but you have to know that a lot of these fractures have a horizontal component between S1 and S2, so it makes no sense then to fix S2 because this is below the fracture level. Also, we did a study on the transpubic screw corridor. So this is the anterior pelvic ring, and also here we use this three-dimensional statistical model with 150 uninjured pelvises. And we found this is the retrograde transpubic screw, as you have seen it already in several examples. And here again, we found that the transpubic corridor with a diameter of 7.5 millimeter, which is the diameter about of this retrograde screw, large fragment screw, spongiosa screw, was only available in 185 of 300 investigated pubic rami, so 150 pelvises. And they had a screw length of 130 millimeters. So it was not possible to bring in a straight screw in about 1/2 of these patients. And that's for me the reason that it makes very much sense to use a CurvaFix implant, because we have heard that earlier, because this implant follows the corridors that are available in the pelvic anatomy. Last picture from my side, you see here some data of from the United States from 2019, pelvis fractures versus hip fractures. You see hip fractures are much more frequent still than the pelvic fractures, but if you look at the population above 65, the amount of operative treatment in the hip fracture is 90%. It's far above 90%, and the amount of operative treated FFP lesions is only 10%. 90% are still treated conservatively. So here is my conclusion. There is still room for further gains, as we have shown that operative treatment, especially minimal invasive operative treatment, may reduce mortality in these patients. Thank you very much for your attention.